thanks for joining us on the program tonight. I am Omini Odan. The challenge of providing a robust health service to all people in every nation is a formidable task, which is why so many right-thinking individuals and organizations get involved in initiatives to achieve inclusiveness in healthcare delivery service to all people. From individuals to corporate organizations, non-governmental bodies, global and localized agencies are on hand in diverse health services that indirectly and directly to make the difference in human life. The Nigeria Women Health has become a global part and national effort in Nigeria to decisively impact positively on the healthcare system of the country. The Women for Health is committed to addressing the shortage of female health workers in Nigeria, but with emphasis to leverage the obvious acute gaps in female health workers in 6 states in the northern part of the country. This has improved the number and capacity of female health workers in the 6 pilot states, and experience and understanding of major gaps found in rural communities with very lean female health workers. The idea is to gradually achieve a long-lasting solution in most rural communities, especially with active engagements of female health workers in the country. In broader mandate, Women for Health facilitates training in so many areas, research and improve access in our rural communities and reverse the underserved challenges in the rural communities, unlike the urban centers. Already, the organization has provoked full accreditation that will sponsor more people in health institutions and gradually and steadily achieve healthcare delivery around rural communities, irrespective of location. This is a welcome development, and for good reasons, government at all levels, corporate bodies should offer support to actualize this national aspiration desired by all Nigerians. Our focus tonight will examine shortage of female health workers in Nigeria, especially in the rural communities, mostly in the northern part of the country. But first, let's take a listen to this background put together by Uche Oguchukwu.
Maintaining and accelerating progress towards universal health coverage. The World Health Organization insisted that a strengthened health policy environment is key to the delivery of quality health care to the population, as it creates an enabling environment for the health workforce, and that health services, particularly at the primary health care level, are critical to maternal, newborn and child health. Regrettably, Nigeria has over the years been faced with the challenge of shortage in human resources for health, following brain drain occasioned by inadequate remuneration and welfare packages, as well as unfriendly environments to practice. However, there are efforts to optimize the available workforce in the provision of quality essential services towards the realization of universal health coverage in the country. As part of efforts to improve human resources for health in Nigeria, the Ministry of Health had called on governments at all levels and private sector to develop human resources that would enhance the provision of quality healthcare services in the country. Admitting that the shortage of health workforce and uneven distribution of available skilled healthcare professionals are some of the reasons for poor healthcare service delivery in Nigeria. The ministry said it is necessary to raise awareness on the health workforce challenges and issues hindering service delivery and the attainment of health national targets, including that of Sustainable Development Goals. In line with this, the National Council on Health had directed federal, states and the FCT administration to establish human resources sections for health desk officers in the Ministry of Health. Also, Nigeria had collaborated with Save the Children International and other partners to boost health workers' capacity in the country.
Uche Oguchukwu's background sets the tone for the takeoff of the program tonight, and once again it is focused on Women for Health, bridging the gap of female health workers in Nigeria. It's Tuesday Live. At some point our phone lines will be open, and when we're told to you, please turn down the volume of the television set. And in doing this, please go straight to the point and don't break my rule. You can also be part of the conversation tonight through our Twitter handle at Tuesday Live NTA. Please plead that when making contributions to the program, please be mindful of your language. Be very, very polite. Don't use abusive language in the course of the program. Well, I have tonight on the program the National Program Manager, Women for Health in Nigeria, Dr. Fatima Adamu. Good to have you on Tuesday Live tonight.
Good evening. How are you?
Okay. Also joining us tonight is the Health Advisor, UK Foreign Commonwealth and Development Office, Dr. Ebere Anyachuku. Good to have you on Tuesday Live tonight.
Thank you very much. Good evening.
Also tonight on the program, we have the Secretary General and Registrar of the Nursing and Midwifery Council of Nigeria, Farouk Umar Abubakar. Welcome to Tuesday Live.
Thank you, sir. Good evening, viewers.
Yin. Doctor, what informed Women for Health in Nigeria?
Yeah, thank you very much. Women for Health is a UK aid-funded program that is meant to address the serious shortage of female health workers, especially in northern Nigeria. The problem of health workers is an equity issue, and where we have shortage, they are not enough. According to WHO regulations, every community of up to 100,000 should have at least 58 nurses and midwives. But here in Nigeria, and especially in northern Nigeria, you can have a 100,000 population, but with no single nurse or midwife. So there is a serious shortage. Importantly, again, it's not only the shortage, but in the northern part of the country, majority of the health workforce are men. And yet our women, due to cultural and religious reasons, they prefer to be attended to by a woman. And another issue that is critical to Women for Health, and that really led to the setting up of Women for Health by the UK aid government, is also, it is more of an urban issue. So majority of our health workers are resident in the urban areas, and not only in the urban areas, but within the urban areas, many of the health workers are in the tertiary institutions, where majority of our women do not reside. And so it's very common. For example, building a hospital, I keep on saying, is the easiest part. But having a health worker to man the hospital and to provide the services our women need, that is where the challenge is. So they are not in the rural areas where majority have, and where we have the problem, higher number of maternal mortality. And without the personnel to really provide the care our women need, definitely one can say that's what really part of the reasons that we have high number of maternal mortality, especially in northern Nigeria.
And that question I ask you is, why choose 6 focus states as against the entire northern part of the country?
Yeah, I think that is more or less the decision between the UK government, the FCDO now, and the Nigerian government. But one of the reasons I know is they have the worst statistics in the north. And you will see in terms of the numbers. So let's take one state, and I don't want to mention, but one state you will see that they have just less than 40, the entire state, less than 40 nurses and midwives. And that is, for the entire state, that is probably half of what a teaching hospital by the federal government has. So you can see the problem. So because the main reasons I know is because they have the shortage, and they are the worst. They have the worst statistics in terms of maternal mortality. They have the worst statistics as well as in terms of the number of health workers that we have, especially the women.
Well, we'll come to the specifics in terms of the number.
Yeah.
There are 6 focus states. We'll
Yeah.
come to that.
Okay.
But let me go to Dr. Ebere Anyachukwu. Dr. Ebere Anyachukwu, quite a novel and mind-blowing achievement you're doing in terms of funding this project in Nigeria. And we ask, would you say it's been a worthwhile venture in Nigeria?
Thank you very much for that question. Yes, it has been an impressive program. It has achieved basically everything that it set out to achieve. Just last week, I was speaking with some of the young women who just graduated from midwifery school in Kano and in Borno, and also speaking with some of their communities, and the excitement at that some of these young women and their communities had in being able to graduate and become midwives and render services to their communities was amazing. And what the program has done is that it has brought to the fore this issue of human resources for health in Nigeria, which is a critical issue. Without addressing this issue, we can't address the problem of health in Nigeria. As we know, Nigeria has really challenging health indicators, and the human resources for health problem is critical to resolving those issues. So Women for Health has made quite an impact in trying to beginning to address these issues, and it remains for the Nigerian government at federal and state level to take on some of these lessons that we've learned from the program and really expand it out across the country to address this challenge.
Would you say, still on you, Dr. Anyachukwu, would you say it would be correct to encapsulate and say that this has brought about a paradigm shift in community medicine in Nigeria?
Well, I wouldn't say a paradigm shift, but I would say it's a big impact. I mean, the fact that through this program we've been able to provide opportunities to young women in rural areas who would never have had that opportunity, who would not have been considered for those opportunities, and today they are midwives. They are rendering services. We've seen in all the states the governors, the politicians, the houses of assembly are paying a lot more attention on human resources for health issues. I think that's a really big change. Now, the challenge for Nigeria is how do we turn this impact into, as you say, a paradigm shift, and that's the challenge that the Nigeria has to overcome. That's what we have to do as a country. Thank you.
Farouk. Dr. Farouk, in between capacity building and professionalism, how do you assess this program for the 8 years it has lasted in Nigeria?
Thank you very much. One, we can say that for the last 8 years, there was remarkable progress in terms of support to most especially the 6 states that Women who have supported. And I want to say it is on record. Before they came on board, there have been a lot of challenge in almost all the 6 states, especially in terms of maintenance, training capacity of these training institutions, and they now go into the training institution, identify what are their challenges. And these challenges include the shortage of manpower, basic training equipment, and other facilities that will enhance training. Now they identify these as a key challenges, and they now dwell into in order to address, in order they did and increase the capacity of this training. And I want to say that today, all the 6 states, all their training institutions, School of Nursing and Midwifery, their capacity have been increased, and they are able to have their accreditation status raised from professional to full accreditation. Their intake increased from 50 to 100, and some of them even up to 150. Now, this is a strategy that was adopted, and it was all the support of the Women for Health. And I want to say that today, this training institution, all the 6 states, they are doing very well. Even their output in terms of the performance of the professional examinations, they have remarkably improved, from ranging from 60 to 70%. Now their performance is ranging between 94 to 100%. This is what I can say about there was remarkable progress and improvement.
Thank you. Dr. Fatima, let's let the cat out of the bag now. Can we hear about these 6 focal states? What are the states?
Okay. I will start with Zamfara, Katsina, Kano, Jigawa, Yobe, and Borno. We added Borno 2 years later, and that is UK aid because of the conflict. And we know what happened and what's still happening to health workers in Borno, and the need for it was really paramount. And so Borno was added. But we've been in the 5 states since November 2012. Yeah.
Okay, now, one of the things that tripped us in this program has been the fact that when you engage, before the participants or the beneficiaries, they sign a bond, and this bond says they go back to their communities to work as midwives and nurses for a minimum of 2 years after graduation. Is this working?
Absolutely, it is working. You know, one thing we learn is that no matter we cannot solve the problem of inadequate health workers in rural areas by still sticking to the status quo. The assumption that we will transfer urban girl, a woman who had established her family with her children and her husband, will pack and go to rural areas in order to service somebody's husband or somebody's wife. We realize that we need to go to the community and discuss with the community and say, look, do you expect somebody's husband to release his wife to come and service her? You have to produce your own. And the interesting thing is that they all accepted that. And we said, okay, if you want to produce your own health worker, then how can we do it? So what we did was that the community said, okay, we'll give you our daughters, we'll give you our wives. And they did. And the reason why we added the bonding, it is because we don't want people to feel they are really bonded. So we said, look, you serve for a certain period. If you like, you can go. And interestingly, out of the over 550 girls we have who had become midwives, not those who are already in training, who had already graduated, they are back in their communities. Only three tried to resist going back. And we reported the case to the government in the state. And the governor and the government took it up. And we showed the bond where they signed. And their parents signed, the community leader signed, and the religious leader signed. So everybody who was there. And you know, when we go to select, we just don't knock at your own door. We have a community meeting. And the community will nominate. Yes, we know this girl. Yes, we agree. The husband, do you agree to allow her? Yes, I agree. The parent, do you agree? Yes. The daughter, do you want to go? Yes. So it's a communal decision. So it's not an individual. So once something goes wrong, we don't go to the girl. It's the entire community.
So at the end of 2 years, they are qualified or they are free to do something else?
If they like, but we have people who have exceeded even 2 years and they're still serving. They are from the community. So, we have this when we talk about the state, your state indigent. People will say, oh, I'm from there, even though you don't reside there. So it's not about indigenship. It's about resident who is residing in that community, in that area. And whether you're from that community or you're not, as long as you decide to stay there, we will support you to become a health worker. And so they go back and they stay. And as I've said, we have more than 98% success. And that's amazing.
So within these 2 years, who remunerates them?
The government.
The focal state government?
The focal state government. It is an amazing thing, the way in which the government, the governors themselves, and it really took up the challenge. The issue of human resource, as Dr. Ibero said, is a national problem. It's a global problem. It's not even national. And they have that challenge. And once we brought this idea, they bought into it. And so as soon as they graduate, and then they go back. Sometimes we can have some lapses of some month, but they are employed by the government. And they are right now. So we have some few challenges wherein sometimes it takes time. But we've gotten the commitment from the government and the governor, especially the governors. The governors are employed them and they are servicing them. Where we have some challenges, we go to the governor and we go to the commissioner of health. And we say, imagine the sacrifice the husband has made. Because we have to appreciate the sacrifice a husband made. Allowing his wife for almost 4 years to leave him and with the children and then go and study. Now that they are back. And the interesting is, as soon as they are back, whether they are employed or not, they just go to the hospital. Because they know that's what the community sent them for. It is to service them. And then while they are there, and they will be talking about the employment and the salary. And that's when we go to the commissioner. I say, Abba, Commissioner, aren't you ashamed that here we are, a young girl, a rural woman, in her community providing services and mingling with a woman's blood, and we cannot pay her money? It is uncalled for.
We'll come to that. Let's go to Dr. Ebe. Dr. Ebe, you are very central to this, and one worry is in every initiative of this magnitude, the challenge is always, or the concern has always been sustainability. The gestation period, from what we have studied, is 8 years, and UK 8 is thinking about exiting. Are you worried about the sustainability of the program?
Thank you very much. And you're right. That is a typical challenge with many development projects. But the thing is, with Women for Health, we thought about that very carefully. And we designed tackling this issue right into the project. So, for instance, right from the beginning, the project had very clear MOUs with the states that stated what will be responsible for and how long we're responsible for those things and how the states will take over. So all those things were planned. So, for instance, the foundation year program, which the project initiated, over the course of the program, the funding for that foundation year program was transferred to the states. So in most of the states now, most of the states even have legislation that provides funding for the foundation year program. And actually, the way Women for Health has been designed even deals with this issue. So in some of the states, we have already actually exited from providing direct support for the last 2 years. And in those 2 years, we've just been providing just limited technical support. And what we've seen over that period is that most of the initiatives have been sustained even without direct support from FCD or from the project. So that's an issue that has been well thought through in this project, and we've tried to address it as much as possible. And I would really want to say a big congratulations to the states, because just this week I've been having discussions with some of the officials in the states, and they've been talking about how some of these initiatives, the funding for those initiatives, have been incorporated into the state budgets, and they've been releasing those funds promptly. We've also put initiatives in place to ensure that after this project, some of the technical work continues. So the project has partnered with the Bayero University to put in a lot of the technical know-how behind this project into the university. So the university is able to provide some of that technical support even after the project ends. So a lot of those things have actually been thought through in designing and implementing Women for Health.
I'm still on you, Dr. Anyachuku. Quite concerned also is, I'm happy you're a Nigerian, is the curriculum used, is it a strictly localized curriculum, or is a curriculum that can best provide even space for these beneficiaries when they decide maybe to go beyond the shores of Nigeria?
Very much. Yes, so in implementing this program, we've worked very closely with the Nursing and Midwifery Council, and we've used the curriculum that is provided and developed by the council. We've also supported the council in improving and adding specific parts of the curriculum. But it's medical training is international. So when you train people, you train them to an international standard so that they can work wherever they choose to work, because human beings are essentially the same. You can't train people to a lesser standard in Nigeria than you would in another country. So it's done to the same standards as are done anywhere else in the world. What we've also done is try to improve the teaching methods, so to bring more advanced and more modern teaching methods into the way that the tutors in the schools actually train the students, and introduce technology into that process. And some of that is what has led to the improved pass rates, very vastly improved pass rates we've seen in those schools. So yes, we are very confident in the standards that the students have been taught to. I think the registrar is better placed.
You are the Registrar Secretary General of the Nursing and Midwifery Council of Nigeria, and the challenge of compatibility, I fear, will play out at the end of this, talking about qualification. What happens to these beneficiaries at the end, at the exit point where this program ends and then the labor market? Are they at par with their contemporaries, given your standard as the registrar of this council?
And like he has says that our training is inclined with the global standard, and I want to assure you that the state is supported, and like what the national program has rightly highlighted, they have signed a bond on most of the states. They support it. At the end of the training, they are expected to go back to those communities and work for that community. So, like he has rightly said, our curriculums in almost all the 6 states is inclined with the global trends. And he also said we are supported by the same Women for Health to ensure that our training curriculums were well enriched, well articulated, and in line with the global trends, so that at the end, all our professionals that qualified, they are free to serve their communities. At the end of their bond, they are also free to move from the community to secondary level and tertiary level and also beyond. So nobody restricts that, but there is also continuous. And even the state, they are also committed in that. I want to add to tell you that one of the interesting things the Women for Health does is support to develop the improved curriculum for the community midwifery. For the last 4 years, the curriculum, the training is not inclined and not linked with the professional training of professional midwife. Women for Health look at this challenge and say, look, let's see how we can link the 2 years community-based community midwifery with a 3 years basic midwifery program. At the end of the 2 years, you go back to the community, you work for 2 years, and if you so, you come back and spend another 2 years, and you also registered as a professional midwife. So now you see the trend. You start from the community base, then you now spend 2 years, go back to the community, spend 2 years, and come back to the school of midwifery and spend another 2 years. Then you become professional midwife. And that will also give you the opportunity to work at the secondary level, tertiary level, and also globally, because the standard is maintained. And this is what I can say. So I want to say that the graduates of these programs, they serve their community, they serve their state, they serve their country, and also they serve globally if they so wish. Nobody can retain them, stop them from moving after serving their community.
Bank of Sustainability, Dr. Farouk, I'm still with you. The worry is most often these beneficiaries will serve 2 years at the rural communities, and at the end of 2 years, a lot of them want to leave for the urban centers. What is your council doing to ensure that, because the deficit, one of the concerns of this program is to close up the deficit gap created in terms of community medicine, if I'm correct to say so. Now, what is your council doing to ensure that even at the end of 2 years, these persons are encouraged to remain in the communities? Because the central focus of this program is training them to save lives. And the major challenge has been in the communities. You don't find health workers wanting to stay in the communities. What are you doing about this?
We did as a council, we now double up the training. We increase the strength. We increase the quantity of the training so that when there is movement from this end to another end, then the number is also increasing. I want to say that we have designed a program where we projected we want to train 50,000 community midwives and 50,000 community nurses. And we also projected that in every political law, we want to train 10 community midwives and 10 community nurses. This all aim true, and it's going to be a vicious cycle, and a cycle while others are moving, another one also coming on board. And we also harmonize and ensure that there is a MOU between the Ministry for Local Government and Ministry of Health in all the states, so that these young women and children, men, after their training, they are returned, and the training continue on that basis. So like you have said, after 2 years of their bonded, and they so wish to leave, another group are already trained and they are also on ground. So they cannot move at the same time, and there is continued based on this particular training. So this is the focus, and this is the intention to ensure the sustainability and the availability of these manpower at the rural areas. And this is the focus.
Dr. Anyachuku, before I come to the National Program Manager, Dr. Anyachuku, by the records, we gathered that so far a total of about 2,801 have entered professional courses since the program began. And 2012 to 2020, this whole thing, UK Aid is about to exit funding this program. The deficit remains 2,801 so far by the population, even within the focus states. And I believe by the time I come to the National Program Manager, she will be telling us maybe some states even need the program. Why, is there any plan maybe to go beyond this 8 years you have stayed in Nigeria?
Thank you very much. And you're right. That's an issue. the challenge of human resources in Nigeria is huge. I recently saw a study that showed that by 2016, we had a deficit of about 84,000 nurses in Nigeria. So we have a long way to go. But what we've tried to do with Women for Health is to show a model that can work. Women for Health by itself, by just that program, is not going to solve the entire human resources for health problems of Nigeria. But it is showing a different way of doing things, a model that can work, that the country can scale up much bigger than our development project can ever do. And that's actually what we are trying to say, that and that's one of the reasons why we've worked very closely with the Nursing and Midwifery Council. So for instance, some of the methods that we and initiatives that we have rolled out through Women for Health are now being rolled out by the Nursing and Midwifery Council across the country. So it's being used all across the country. So while as a project we are not able to roll out the project across the country, but the learnings and the initiatives are applicable everywhere else. And we are encouraging, and there's nothing about those lessons that can't be implemented by states on their own. They're actually quite simple. We've worked really hard to document the steps and that Women for Health has taken. So for instance, on the Foundation Year program, there's a very clear documentation about how a state can go about doing it on their own. And it's not so difficult. There are 1 or 2 states already which are not supported by Women for Health, are already beginning to do this on their own. And would encourage more states to do this. And as more states continue to do this, and the federal government takes it on, it can begin to make a much bigger impact across the country to address this human resources for health issue. Thank you.
2,801 have entered professional courses since the beginning of this program. That does not mean that's the number. The number that is far bigger than this, right? So what M&E do you have in place monitoring these ones who have gotten professional certification and those who are yet to get? What plans do you have so that they too can be professionally certified?
Yeah, thank you very much. As Dr. Iberi mentioned, for the past 2 years, the state government have taken them over. And they have a structure, what they call Foundation Year Working Group. And that's, so of course before them we have our M&E. And the state government had taken over such M&E as well, the M&E system. And they have adjusted them to suit the way they want it. And so we have also at the community level, what we call the advocacy group. And those are the ones monitoring what is happening. So making sure, because that's very critical, making sure that elite did not capture the opportunity. It remains the opportunity meant for rural and disadvantaged women. So it's not taken over by my child, my daughter, or your daughter, for example. It's really meant for that. And so we have that M&E to do that. And so what we did was to bring the state government that is funding and bring the community together and to be monitoring that. And in terms of professionalism, I mean in terms of the quality, as they all said, the girls, the young women and the women from the rural areas, they are coming and joining everybody. So they are not having a separate training. They just follow the normal. The only thing we do is that we keep them for certain 6 months and really coach them in sciences, because because they are from the rural areas, so they have the disadvantage of really good background in sciences, and if they are to meet with the rest of their mates, they might not be able to compete with them. So we groom them, we prepare them, so that when they come and join any other girl or boy, they will be able to succeed. And some of them, interestingly, they even join and perform better than the rest.
Okay, that takes me to the monitoring and evaluation. What's the entry requirement? Because you're talking about young girls who are in the rural areas. By my imagination, I imagine a lot of them may not even have the basic education. So what's the entry requirement?
So they must.
I'm happy the registrar of the Midwives is right here with us.
Yeah, it's the same requirement. So they must have secondary school certificate. They must have the required credit as stated by the council. So because they are from the rural area, that does not mean some waiver is given to them, no. So the responsibility of Women for Health is to groom them and support them to meet up the requirements set up by the council. So yes, we make sure that yes, academically, socially, psychologically, they are prepared for that. And you know, they get a lot of support from the community, and the community visiting them. So they have that moral and motivation from their community. That really helped a lot.
Okay, now let me ask you a practical question.
Okay.
Now, Dr. Fatima arrives at a particular community to recruit would-be beneficiaries.
Yes.
And in this community, the most qualified is yet to have the basic first school living certificate, right?
Hello?
And this fellow is very enthusiastic. What happens?
So first of all, you must finish secondary school. You can wait for another set, but for that set, you must finish secondary school. If you don't have the required credit, you can pass through what we call bridging. We have the bridging program, and that is complete 1 year, wherein we groom you, we train you, and for you to rewrite your WAEC and NICU and get the required credit. You cannot go into the nursing and midwifery without those 5 credits. And 5 credits in sciences, as we know them. Physics, chemistry, biology, English, and math. You must have them. And these girls, they have them. So if they don't have, the interesting is they are very bright. Some of them, we started with them, they can't even speak English. Within a short period of time, you will see them catching up. And they make it. So they need support. And I think that is what I've learned about Women for Health. Our young women, our young boys, they need the support, the push. So quite a number of them in the entire community, they have never, she might be the only one, or there are very few who have completed secondary school. So and that's why they became role model in the community, and what we need, and that's why I'm very proud of our governors, and who had picked that up and really supporting them, because without that support, they wouldn't have been able to make it. Yeah.
Okay, Dr. Ebere Ayachuku, quite interesting, and I believe a lot of Nigerians listening to this program will feel so enthused.
Hello?
Nigeria is huge, and this program, by the records, is focused in the northern part of the country with 6 focal states. By the accounts of the National Program Manager, states that never even benefited have picked into it, and they are trying to replicate it. Now, if we ask UK Aid, maybe the Nigerian government approaches UK Aid and says, please do more, extend your dragnet to other states in the north, and maybe replicate it in the southern part of the country.
Hello?
Will UK Aid still be
Hello?
leaving Nigeria?
Hello?
Well, that's an interesting question. The thing is, I think one thing we have to recognize is Nigeria is a big country. It's a huge country. And the amount of development assistance, not just from UK Aid, but from all the other partners that support this country is quite limited relative to the size of the country. So the focus really our focus in UK Aid and also with many development partners is not necessarily to provide all the resources that Nigeria needs to address some of these challenges, because there's no way we can do that. We don't have those resources to provide, but to look for opportunities like this, where we are able to show how things can be different, how by just changing the way that we do things, we can actually make quite a big difference. And I think there's something, this particular program, one thing that it really demonstrates is, and as Dr. Fatima mentioned, the power in our young people as a country, the power that this country actually has is in our young people. That when you empower them, you provide them those opportunities to really show what they can do, you can really generate quite a big force that will power this country towards development. And we've seen that with those young ladies that we've supported through this program. Many of them, many people would never have given them a chance. Many of them didn't think they would ever have an opportunity like this. But that's, I think, the big lesson that we've learned, that if Nigeria can, using its own resources, empower our young people more, they can do things that we never thought possible, or we never thought they could do. And the challenge really is for Nigeria to take on this lesson and begin to think through not just Women for Health, but other similar programs like this that empower young people to really begin to make a contribution towards development in the country.
Okay, it could bend backwards. It's okay. Let's do additional 2 years.
Additional 2 years of the program. Well, the thing is, we've achieved essentially most of what we set out to achieve in this program, and in many of the states we've already handed over most of the initiatives to the government, to the Nursing and Midwifery Council. Yes, we can continue to provide ongoing some level of technical support through our other programs, but I think this program has really achieved, and it has essentially achieved what it set out to achieve, which is to demonstrate that this is possible and that Nigeria can actually do this.
So Farouk, a tweet had just come in from Adebayo Samuel. It says, "Women for Health should be applauded for such a wonderful initiative by bridging the gap for health workers in the rural areas to eradicate maternal loss of our mothers in the rural areas. Keep it up." How do you react to this tweet?
For this tweet, and I want to say basically that I share your own view that if the DFID can expand this program for additional, not even beyond the 2 years, that would be, and if there is opportunity to expand it to other parts of the country, and I think Nigeria will benefit greatly. And more importantly, I want to add to say, with the support that we have gotten, the entire country has also indirectly benefited. There are a number of programs and other initiatives that was put in place at the council through the same Women for Health, through their funders. And I want to say that Nigerian, that National Midwifery Council expanded the same of these program initiatives, such as Student Information Center, Student management, student information management, SIMS, e-learning concept, training of preceptors. These are all the part of the support we receive from the Women for Health, and these are it have become a national program today. It's not only a program for the 6 states supported. The entire 36 states training institution of nursing and midwifery benefited from this initiative, and that has improved their training capacity logically. So I want to say that what the person who tweeted has now suggested could have been, if there is opportunity, this program can be expanded to the entire country, and I will tell you, the benefit will have gone beyond what is achieved, especially in our rural areas. Thank you.
Is your council not challenged with the development on ground? For instance, Dr. Ebere Anyachukwu has talked about the fact that as much as UK Aid is exiting this program at the end of 8 years, there's a technical collaboration between the Bayero University and this program. Is your council not thinking towards maybe trying to create something near this to continue with this? Because it is one way of building capacity and bridging the gap of healthcare delivery at the community level.
Well, I want to say that the program he has mentioned that was put in place, we are part of it. And I want to say we have just granted approval for the credit, for the award of credit of one of the programs in that university, and we are part of it. And the same program, like I said, has also been expanded. So we are also not challenged, but because we improve on our statutory responsibility, and we use the lesson that we learned from the Women for Health support to expand our statutory responsibility to entire country. And like I have tell you that, for example, the e-learning concept, which is a concept that was brought to us and supported by Women for Health, and I want to say that it's a concept that today entire training institution of Nigeria are so much proud, and is creating a lot of positive impact in almost all our training institutions. The issue of also training our preceptors. We receive a lot of training, a lot of support from the Women for Health, where we empower our preceptors that have been identified from almost all the teaching hospitals, paramedical centers, and other secondary institutions across the country, and they are all trained. And this all training is of support. We have identified trainers of trainers in almost all the states, and they were trained, and they are now empowered to go back to those facilities, identify other preceptors, and continue training. And these are all part of the initiative and support of the Women for Health.
Much of your time, Dr. Farouk, still on you. Where is the place of accreditation in all this?
When you talk of the issue of accreditation, accreditation is a strategy to ensure that institutions maintain standard in training nurses and midwives. And we receive a lot of support. I want to say that today, because of to avoid any attempt to compromise the standard, we receive support. We develop a software where we are going to initiate what is called online accreditation of all our training institutions with the help of the Women for Health. And this support is not only limited to only 6 states, it's going to serve the entire country. And this is also part of what is benefited from this particular project. And I want to say that they have supported the development of software. They also supported in providing the phantoms that will be used in the same exercise. They supported in pre-testing of this particular exercise. We tested this software in about 6 selected schools of nursing and midwifery in each of the one selected geographical zone to ensure the workability of this. And I want to say that as they are rounding up, we are also making arrangements to see that we make necessary conclusion to ensure effective working of these tools and this support that was provided to us, so that we continue to remember the legacies and the support of Women for Health even after their exit, and so that the entire country continue to benefit on this particular support.
our break on the program before we continue. Let me ask Dr. Fatima this. You expressed worry at the beginning of this program that majority of the health workforce in Nigeria now, not just northern part of Nigeria, is a male folk. And this program is targeted at women, though at the northern part of the country. For 8 years, would you say this deficit has been kind of shot up?
Thank you very much. I think we've moved we've moved a little bit, but and this is the shortage is more the men dominance is more of a northern problem. In the southern problem, it is not the case. So we move that, but I think there is still a problem. So, for example, and in working with the state government, so they have even in some schools, they have even made the admission criteria to make it 60 female, 40 male, in order to bridge the gap. But still, we still have that shortage. And so I don't think we've bridged the gap. And so in terms of doctors, it's even worse. And I think the same thing with pharmacy. So we've been talking about nursing and midwifery. We know midwifery is all women, but nursing is still we still have men dominant in the north. But what we succeeded in doing, is really highlighting the challenge. And the government had taken it up and said, okay, henceforth the admission will give more admission to women and the men. And we estimate that in the next 10 years, we will balance it up. But as it is now, it's still more men.
Okay, now let me veer off a bit. And veering off a bit, I want to discuss something very fundamental, yet related to women for health. And that concern is the problem of brain drain, migration. By the records we hear, and I want to tailor this question to Dr. Ebering Anyachuku. In the last few years, I can't specifically say maybe 2 or 3 years thereabout, we hear over 5,000 nurses and midwives have left the shores of Nigeria for greener pastures. And if this program is meant to bridge the deficit in terms of female health workers in Nigeria, mostly at the rural level, if, for instance, from what the national program manager is talking, Dr. Fatima is saying, the states are not able to hold them by way of welfare packages, remuneration and what have you, in the next 6 months after UK aid exits, they too choose to go for greener pastures and exit the country. Is it a concern?
Thank you. That's a very important question. It is a very serious concern, and it's not just nurses and midwives, it's also doctors. As you know, the country is seeing an exodus of medical professionals from Nigeria to many other countries. Now, that's an issue that we've also tried to address within this program, and that's why, because we try to look at the fundamentals of the issue. One of the key reasons why that is happening is because we are not having poor recruitment and retention of the nurses and midwives. So you find a situation where quite a number of nurses and midwives actually graduate, and they can't find good jobs, and so their next step is to try to leave the country, or when they do, for one reason or the other, the country is not able to retain them. So one of the things we did in the Women for Health was to set up a midwives recruitment and retention scheme, where we partnered with a number of the states to recruit more midwives, and also strategies to retain them, to ensure that that they are comfortable in their jobs and in their positions, and that whatever is needed to keep them in those positions is provided by the government. And with that, that's been quite a success. I mean, through that program, a number of those states have seriously increased the number of midwives that they recruited a lot more midwives, and they've been able to retain them. And we think that if the states are able to improve recruitment and retention practices, then that will help to curb this issue. So I think that's the thing. You can't force people to stay in one country or not. What the best you can do is to ensure that the conditions in the country are favorable to them to stay, and that's one of the things that we've tried to show through this program.
Are you worried in this direction? UK Aid came up with this initiative, train young girls. They are doing very well, just at the verge of bridging the gap, the deficit gap in terms of female healthcare workers in the rural communities to boost community health in Nigeria. A couple of them will find their way out of the shores of Nigeria on account of the fact that maybe welfare packages, remuneration is not taken care of. And your council could do something here. It's not just about regulating. Are you worried that this could happen if your council does not maybe wake up, first of all, to these 6 focus states to say, do A, B, C, D to hold down these professionals who have been trained on account of Women for Health in Nigeria?
For these questions. And I want to inform you that, and other viewers, that we paid advocacy visit to almost the state. We advocate for the various state government within that 6 states, which the Women for Health supported, to come out with initiative, a retention ability, a retention modalities of how they can retain this. Because basically what is important, these professionals, they are at the community level. And this is where the gap and this is where the challenges are. Now we advocate to most of the commissioners we have been discussing, telling them the importance of retaining this community. And like what Dr. Abuja has said, it's not the issue of remunerations. Sometimes major challenge is the issue of working tools and working equipment in most of our hospitals. But I want to say that the present government of the day is doing all it possible to ensure that adequate facilities are provided in most of our tertiary institutions, so that these professionals have seen the working environment conducive for them to stay and work. It's not the issue of remuneration, but when the environment is also conducive, I believe they are also willing to stay and now support their nation in order to provide better and qualitative healthcare services. A lot of programs, a lot of initiatives have been put in by the federal government through the Federal Ministry of Health in order to ensure that adequate facilities were made in order to make the environment conducive for delivering of quality and effective healthcare delivery, including the nursing care. And at the council, we're also trying to roll over a lot of global trends that will entice and ensure that it's put in place in almost all our health facilities, so that the nurses and midwives see the need to stay at home and improve the service delivery and work for their own people. So like what Dr. Obera has said, nobody can retain anybody. But we are trying as much as we could to ensure that the environment is conducive. And I'm sure even on terms of remuneration, it's not all that bad that you are saying as compared with other African countries or other countries surrounding Nigeria. They're not comparing with other developed countries. Thank you.
I know you have addressed what I'm about to put across to you differently, but let me just pass it across to you. A tweet I just come in here is coming from Akpoguma 123. It says, the program is a nice one and it is good for the growth and development of the country. But looking at it, it is one-sided. And the tweet says, I think you should as well look at the riverine areas that are not easily accessible, also lacking in things like this. How do you react to this? You see, Nigerians are speaking now.
I think I share the same view with him, and that's why I also share the same view with you, that if the DFID can look at the possibility of expanding this program, not only in the 6 selected states in the northern Nigeria, can now become a national program, probably randomly selected in all the 6 geographical zones in this country, even if it is 1, 2 states selected, and now provide, but however, he has given a caution to say that all issues related to funding, and each program has its own scope and it has its own focus. So we hope other partners that are in the country, and I believe they are also doing their best. There are other partners that are working on other parts of the country, but all I will say that they should also probably take a cue of what the Women for Health does, emphasizing, looking at the rural areas as their area of mandate and probably the area of focus. So if other partners can also give the same focus, I believe positive impact will be achieved in all parts of the country through this approach.
Recent genuine concerns and agitations by Nigerians about the excessive use of force and, in some cases, extrajudicial killings and wrongful conduct by men of the Nigerian police force. The disbanding of SARS is only the first step in our commitment to extensive police reform in order to ensure that the primary duty of the police and other law enforcement agencies remains the protection of lives and livelihoods of our people. We will also ensure that all those responsible for misconduct or wrongful acts are brought to justice. We also deeply regret the loss of life of the young man in Oyo State during the recent demonstrations. I have directed that the circumstances of his death should be thoroughly investigated. Meanwhile, it is important to recognize that the vast majority of men and women of the police force are hardworking and diligent in performing their duties. The few bad eggs should not be allowed to tarnish the image and reputation of the force.
NTA Tuesday Live, a network issue-oriented innovation talk show.
And just before we had that abrupt break, I was just about taking on Dr. Ebere Anyachuku to react to the tweet which the registrar of the Midwifery Council had already done. Now you could see, as much as you have addressed this differently, you see Nigerians are begging and asking any plans for the riverine areas. Or just like the registrar said, if maybe you're consulted, what will you be telling the federal government to make this a national program?
That's exactly that's exactly what we'd like to see, and that's one of the reasons why we've worked with Nursing and Midwifery Council, whose remit is covers the entire country, and as he has said, a number of the initiatives that we have promoted through this program are actually nationwide. So the e-learning is actually being promoted nationwide by the Nursing and Midwifery Council, and a number of the other initiatives are also promoted nationwide. And actually, we've also made a provision for any state that needs some of the technical support or some of the guidelines that guides that we have produced through this program to actually have access to those through our collaboration with the Bayero University. So actually, I mean, any state that needs this support, they can't actually do it themselves. Everything has been broken down in such a way that any state that wants to implement this can do it without requiring any external donor to provide that support. So states that the riverine areas or the states that have those areas can actually implement this by themselves with that support. There's nothing too technical about it that can't be done.
But tonight, let me take this tweet to Dr. Fatima. Dr. Fatima, Dumebi Mwabweze says, after the training, how do we get help? Do they employ people from the community and teach them too? That's the tweet.
So after training, after they had become nurses and midwives, because I don't understand the question very well.
Now, the tweet says, after the training, how do they get help? Do they employ people from the community and teach them too? That is, train the trainer.
No, there's nothing like train the trainer. They have to go through the complete 3 years of training. As the registrar pointed out, the issue of standard is very critical. We're very proud with the quality of our students. And so but what they do, of course, because they are part and parcel of the community, they work hand in hand with, let's say, our traditional birth attendant, our TBAs. So they work with them. So once a woman is in labor, the TBA will knock at their door and invite them for them to go and render service. And the TBAs also support them with some promotion activities.
So what's the TBA, please?
The traditional birth attendant.
Okay.
The traditional birth attendant, they also support them with promotion activities. So as I said, it's about standard. They cannot step it down to anybody. If anybody wants to become a health worker, must be in the health training institution, in the colleges of nursing and midwifery, and spend the 3 years, minimum 3 years that is required.
Okay. We'll continue with this discussion. If you're just joining us, we are taking a look at Women for Health program in Nigeria, bridging the gap of female health workers in the country. We'll take this report put together by Aisha Obali in sustaining the conversation tonight.
In 2003, Nigeria has embarked on a process of reforming its health sector. The reforms aimed at significantly improving the health status of Nigerians and reversing the high prevalence of maternal and child mortality. A major challenge to the implementation of the reforms and the achievement of the Sustainable Development Goals related to neonatal, child and maternal health and tackling priority diseases such as HIV, AIDS, tuberculosis and malaria is a shortage of human resource. The sector in Nigeria is facing a major human resource crisis with an uneven distribution of available workforce and the increasing brain drain resulting in shortage of critically needed health professionals. Observers recognize that qualified human resources are critical in the provision of quality health care. Evidence points to the fact that areas with lowest concentration of health professionals have the worst health indices in the country. To address the current crisis, therefore efforts are being made to reposition the public health sector to work in close collaboration with the private sector and partners to mobilize resources to develop and retain capable and motivate health workers in their right numbers and in their right distribution. It is essential for overcoming bottlenecks to achieving the national health goals. Inequitable distribution and shortage of health staff are caused by a number of factors, including variation in hiring arrangement as health professionals move from one location within the country to the other. As hiring arrangements in some states do not favor non-indigenous, mobilization, allocation and utilization of health resources are fragmented among different players. Activities of private sector health providers are poorly coordinated. This affects staff development and utilization. There are no standards to guide staffing and their utilization for both the private and public sectors. This National Human Resource Strategic Plan has been developed as a follow-up to some government policies intending to address personnel shortage. The strategies and activities in the plan provides a framework to guide and direct interventions, investment and decision-making, and the planning, management and development of human resource for health at the federal, state, local government and institutional levels. The focus of this human resource for health strategic plan is on developing the most appropriate, visible and cost-effective means of strategies for ensuring equity in staff distribution and access to quality care irrespective of geographical locations. What can government do to address these issues? Guest on Tuesday Live will shed more light.
Thank you there, Aisha Obali, on that report. Well, Dr. Ebere, I'll come to you. Let's sustain from Dr. Fatima. Dr. Fatima, a tweet came in while the report was on from Murtala Abdul Wahab. Women for Health program has done wonderfully well. We will live to remember the program because we are still feeling its impact in our communities. Murtala Abdul Wahab is sending his tweet from Yobe.
That's one of our states.
So can we hear from you?
Yeah, Yobe is one of our states. Yes, it is. And as I've said, we have them in the community already. And we realize, and the statistics from the hospitals where they are working, it's shown very high increase on the number of women going for antenatal, the number of women going for delivery. You know, one of the biggest challenges we have in Nigeria, women go for antenatal, but when it comes to delivery, they run away. They don't want to go to. So, but the presence of a female like them, there is increase in that. It has also increased the uptake of family planning because it is a woman they can sit down and chat and discuss and advise. And so we've also noticed that. Importantly, for us, it's the way in which it has some spillover effect. When we started getting the young women, there was a lot of opposition, resisted by the community. In fact, some said, you know, they think, look, she should have been married. Or look, she's going to go into immorality in the urban centers. There were all kinds of accusations. But interestingly, that has changed. And women have now, where the community has, the communities have positive view. Majority of them now can see why they have challenge of teachers. Some were able to link this program to the reason why they have shortage of teachers in their communities is because their own girls are not going to school. So some communities have saved some money and are sponsoring additional girls to go into the different health training institutions for them to come back. So the question you raise, what happened if they go? The communities have taken up that challenge. They are sponsoring more girls among themselves and for them to come back. So even if she marries and left the community, there will still be somebody. And I don't think there is any community now that will miss this opportunity now that they have seen the importance. You know, one thing with delivery, giving birth, it comes anytime. It can come in the middle of the night. And if you have a health worker that is in another town or in another village, how will you attend to? And so with the health worker close by, all they need is to go and knock. And the health worker, the midwife, will come to attend to their wives. And the interesting thing is the support these midwives and nurses have even gotten from their husbands. The husbands will be the one to escort them to attend to the woman giving birth. So as I've said, it is a community effort, and I think that is what makes Women for Health unique. It's not I, Fatima, going to become a health worker. It is more than that. It is the entire community that are really...
Do you have a case maybe where a trainee or a participant at the end of graduation, rather than work with the state government, the community owns her up and employs her to do the services in the community?
No, we don't have. But what we have is in a situation where she graduates and then she goes back. Before the government can, as I've said, we used to have gaps. In most cases, the community will be giving her allowance until she's employed by the government, and then so we have a community at that period. They will be giving them some allowances and really and then supporting them with all kind of a thing. Even when they were in training, the communities, when they are going back, the community will be giving them, is it soap, is it rice, is it all the support. We have what we call community sponsorship. When we go to select, after the girl is selected, then we will say, okay, community, what is your role in supporting this girl to become a health worker? So one may say, okay, I'll be buying her soap. Another one will say, okay, I'll be buying her this. Another one will say, I will be praying for her. We have some communities, every Friday, they put her in their prayers in the mosque. Let her succeed in her work, in her study, and come back and service them. So it's very interesting the way in which communities have really owned up to this intervention and really moving it forward. And we have cases where the communities follow up with the government and even went to the media and said, look, we have our daughter who had been trained. The government is here to employ her. Please employ her. And the government will listen. And they will talk to their legislators. And so what I'm saying is the way in which the ownership is handed over.
I'll come to you on a particular issue. Let me not let the cat out of the bag.
Okay.
Dr. Anya Chuku and Farouk Umar Abubakar, this tweet, I want to address it to you. Let's see how you react to it differently. It's coming from Francis Arinze. It says, professionals have been trained and they moved in search of greener pastures. You guys are doing a good job of training more professionals, but they will continue to live in search of greener pastures till the grass, this side of the field, is made greener. Does that pose a challenge?
Well, indeed, it's a challenge. And like I have said earlier, fundamentally, nobody can stop anybody from moving. And the government is doing all it takes to ensure that there is retention of these health professionals at all levels. And that's why what the women have initiated at the community level, identify a community base, train that community base, and go back to the same community. And what we did as a council to ensure that it's a joint MOU between the Ministry for Local Government and that of the Ministry of Health, and in between the primary healthcare development agency of the state, to ensure that at the end of the training, we are not throwing this professional just on the street to look for a job. No. It's a community-based train, and there was MOU. At the end of the training, she will be employed and go back to the same community. And by the time doing that, you are making her to attract, to see the need that she was trained to go back and support the community and serve the community. And this is also a strategy that has been adopted almost to all the states. This state that have adopted, and the same modality has also been extended to other states not supported by Women for Health. And I want to say that such modality has been working almost to all others, not only in the northern Nigeria, and almost to all the states. I do remember I had a lot of interaction with some. For example, I'll give you an example of Cross River. Cross River Commissioner of Health has adopted a lot of policies of this approach to ensure that a number of communities were identified, trained, and go back to the same community and serve their community. So I know something in Bauchi, it is similar, and it is not supported by Women for Health. Gombe, it is something. And these are all the states that are also doing this kind of policy. And the same thing, Sokoto, they are also doing the same policy, and they are not supported by Women for Health. So like I said earlier, what we have learned from Women for Health has begun to be expanded to utilize by other states in order to ensure that there is accessible and the availability of these health professionals, mostly nurses and midwives, at the grassroots. That is the real area. And that is our focus, and that is the emphasis. Thank you.
The panelists to address this issue. Let me now hand over to Dr. Anyachuku. How do you address it?
Yes, thank you. As Dr. Fatima and the registrar has said, the way this program was designed was basically targeted at addressing this issue. So we focused on those rural girls, those rural young women. And what we find is that because they are in that community, and those communities have ownership of the whole process, the likelihood of them, and they live there, all their roots are in that community, and the community played a part in their selection and even their training. The likelihood of them leaving that community and going elsewhere is much, much lower than if you were to get, let's say, a young woman from an urban area. So that design is actually built in, and we've seen it's actually working. The other thing that we've done is that through the program we've encouraged the training institutions to introduce, in line with the task shifting policy, to introduce new cadres of health workers. So many of the institutions have introduced cadres like community midwifery, and community nursing, which are also qualified health workers, but they are not as internationally mobile as the nurse midwife. And so with some of these additional cadres of health workers, we're able to expand the numbers of health workers they are able to train, but also to retain more of them because some of those other cadres are not so internationally mobile. So and this is actually working. And as more states continue to do this, we expect that the ability to retain the health workers that they've trained will improve.
Adamu, to react to this.
Yeah.
It's a general question.
Yeah. The issue of retention of health workers is a difficult one. And this is more so, it's not even the remuneration alone. You know, there are other factors. As Dr. Iberi mentioned, you know, in the past, when there is a hospital, there is an accommodation. So now, generally, government built hospital without providing accommodation for the health worker, and which was contrary to what used to be. And so
Doctor, just a second. Let's take our first caller tonight.
Okay.
We have had challenge of Amarachi is calling from Ebonyi State. Hello, Amarachi.
Good evening.
Good evening, Amarachi.
Hello.
We can hear you. Go ahead, please.
Okay. Good evening.
Good evening.
I'm watching your program. I'm interested. Hello.
Go ahead, please. We can hear you. Go ahead.
Okay. I'm watching the program on air now. I appreciate what you people are doing, and I want to be part of I want to join the school, so I want to know the process, how to go about.
Okay, thank you, Amarachi. Doctor, Amarachi is asking how she be part of this program. Calling from Ebonyi State.
Big question. Unfortunately, my sister, we only operate in 6 states. If to say it is
Maybe you need to mention the states again.
yeah, okay, we only operate in 6 states, and that is Borno, Yobe, Jigawa, Kano, Katsina, and Zamfara. And unfortunately, we don't operate in Iboyi. But that doesn't mean that, as we all said, we're calling on the state government to really come into, because what it does, it gives opportunity to the underprivileged group who wouldn't have been able to. And we're calling on all the state government to do that. And you will be amazed, the way in which it has, I keep on saying, it has this spillover effect in the communities. And it's very critical that we're calling on all the states to be part of it.
I just hope the state governments are watching and they're also hearing. We hear the registrar talk about the fact that Cross River, Gombe, Bauchi, Kaduna State.
Kebbi.
We actually come to that.
Yeah.
So that let them know that besides the fact that UK8 funded this project, other states can also maybe copy it, emulate it, and replicate it. Maybe go to these focal states to find out what they are doing. Let me allow you finish.
Yeah, no, absolutely. They can go to those states, and as Dr. Ibero said, we also we set up what we call learning hub in Bayero University, Kano, and that is supposed to provide all the technical support needed in order for other states to emulate and replicate. So we are available to provide those technical support for any state that is interested. And I'm sure DFID is also happy, will be happy to receive. That's the UK8 will be happy to receive that kind of request from any state government.
Okay. Where I was going is exactly what Amarachi from Ebonyi called to ask. And we hope maybe the Ebonyi state government is listening, and so many other state governments are listening to this program, to see this lofty program, Women for Health Program, W4H. That's the acronym.
That's the acronym.
So let's find out from you, 6 focal states, and you've just told us in the northern part of the country that other states keyed into this seamlessly. And the registrar, Dr. Farouk Umar Abubakar, has mentioned Cross River, Gombe, Bauchi, that are also keyed into it. But let's take this caller from Zamfara State. Abubakar is calling from Zamfara State. Hello, Abubakar. We lost that caller. So how did they key in? Maybe others still want to copy from there.
Yeah. So normally, how will they key in? So for example, we have Kaduna State, who had already set up a system. They've even gone into it. So they need to contact us. Contact Bayero University, the Learning Hub, Faculty of Nursing and Gender for Center for Gender Studies, and that's the Learning Hub. And we have also a website. They can search for Learning Hub, Bayero University, and they will find it. So what I'm saying, we are ready and willing to do that, and to provide the necessary technical support that they need to be able to do that. The simple fact is, and it's very simple, we have a lot of materials also, what we call how to do guide, how to set up the FYP, how to do all that needs to be done
Just a second, Doctor. We hear Usman is calling in from Jigawa State. Hello, Usman.
Hello, good day, sir.
Good evening. Go ahead, please.
Hello, sir. Sir, I'm just calling up. There is a question, yes, that was passed to the Registrar of National Midwifery Council concerning the brethren of nurses and midwifery from Nigeria to other countries. So the major challenge is that most of the hospital, as you said, there is serious problem about the equipment recruitment and other things. And what is really bother about is that the different package and other salaries of the workers in the country. So, and the major thing is the interprofessional conflict between the other health professionals. So that would make other nurses and midwives to brain drain from Nigeria to other countries. So because once you see someone move from Nigeria to other countries, you see there is a greener posture compared to Nigerian government. So government has to do something about nurses in Nigeria so that they can return them both on their package, accommodation and other things, so that things will move smoothly.
Thank you, Usman. Usman called from Jigawa State. Farouk Umar Abubakar, I believe you want to react to that call from Usman before I allow Dr. Fatima conclude our line of thoughts.
I want to react to say that government is highly sensitive about this menace, and as a council, we are also sensitive and fully aware of this brain drain, and what we put a policy on ground, or rather measures to ensure that we train more nurses and midwives in order to replace those that are leaving this country. And I also want to add that a number of policies and measures are put in place. If you look at the 2021 budgetary provision, especially on health, a lot of measures, a lot of provisions were made to improve the provisions of basic equipment and other facilities in most of our hospitals. And at the primary health center, if you look at another measure the government is putting in place, because like you have mentioned, one of the major challenges is a lack of accommodation at the rural areas. Government is also trying to ensure that accommodations were provided in almost all the primary health centers. Basic facilities required to discharge, to carry out their responsibility or to give to deliver effective and quality healthcare are also made available. So there was remarkable improvement and a lot of plans in order to ensure that the environment is conducive. And at the same time, these professionals will be able to work diligently and now stay in their country and contribute their own quota in national development. So I quite agree with what you have said, but as a council, we are also very highly sensitive on that, and that's why we increase the intake almost to all the schools of nursing and midwifery, so that in preparation of these challenges, at the same time, so that while others are leaving, others are more trained in order to remain, in order to close the gap that is being created by the brain drain. And I also want to add that a number of policies where the employers of these professionals are also trying their best at their own level of authority to ensure that these professionals are retained, so that they can be able to discharge and give the quality health care to our people.
Let's take this caller from Lagos. Esther is calling from Lagos. Hello, Esther. You're on to Tuesday Live tonight.
Okay.
Go ahead, please, Esther.
Good evening.
Good evening.
Good evening. I'm interested in this. Okay, good evening, sir.
Go ahead, Esther, please. Go ahead, I can hear you.
I'm interested in the program. If they can extend this program to Lagos State, I'm very glad.
Thank you, Esther.
So
well,
people
Dr.
in
Fatima.
Lagos will benefit from it.
I think this I directed to Dr. Fatima and Dr. Anyachuku. Amarachi from Ebonyi is requesting for it to come to Ebonyi State, and Esther is requesting it to come to Lagos State. That is another question. Can you react to it?
Yeah, we will still give the same answer that we welcome the states to come and replicate what we're doing. And we would love to have Lagos, Ebonyi, and any other state. And I'm sure FCDO as well, UKAID will be glad. But so far, that is what I will do, because we don't have the mandate to go beyond. In fact, Women for Last ended, end of this October. So we don't have the mandate. It is a good program which I would love to have it in all the states, including my states.
Okay, Dr. Anyachaku, I think the registrar had said, besides the fact that UK 8 is exiting with Women for Health in Nigeria, he would have loved it to be a national program. And by the phone calls coming in, the tweets coming in, it suggests that it's a lofty program that everybody will want to have in their states. Are you thinking towards maybe before you exit physically, maybe to address one strategic group in the country, the Nigeria's Governors Forum?
Thank you very much. I think that's a fantastic idea to bring this before the Nigerian Governors Forum. But I believe that many governors may be watching this program already. That's a great idea, and one that we will actually look into.
Generally. And I'm bothered because when you talk about community medicine, most often it looks as though it's like a lip service without anything on ground. Even when there is, when you go, you don't find it until we put together this program, Women for Health in Nigeria, which is W4H. Now, how do we revamp community medicine in Nigeria? Beginning from you, Dr. Anyachaku.
Thank you. Yes, so that's a complex issue. So that's essentially revamping our primary healthcare system, and there's a lot that we need to do. Right now, our health system is in a state of crisis, but I think already there are initiatives that are already ongoing, many of which are supported by FCDO and other donors to revamp it. Earlier in this program, we saw the little clip about the National Strategic Health Development Plan, and one of the priorities there is to have the Basic Healthcare Provision Fund, which will help to address the issue of financing around primary health care in Nigeria. I think the number one priority really in trying to revamp it is getting that Basic Healthcare Provision Fund started and operating in Nigeria. Because what it will do is that it will provide funding behind the primary healthcare system, and some of that funding will go into things like human resources. It will go into providing commodities, drugs, consumables. It will go into infrastructure, improving the actual facilities in the health centers. And when all of these come together, you begin to find that health workers will be more inclined, when they have all the things that they need to operate, they will be more inclined to stay in the health centers and be retained and actually do their work more effectively. So I think I will say the number one thing priority that we need to do is to really implement that Basic Healthcare Provision Fund and actually expand it from the 1% of the consolidated revenue fund to even greater than that, because I think it should be a priority right now. And I'm really glad that the Ministry of Health has taken this up, and they are beginning to implement this in partnership with the agencies and with the development partners.
Abubakar, you are the Secretary General and Registrar of the Nursing and Midwifery Council of Nigeria. Community medicine in the Nigerian healthcare value chain. How do you revamp it? Let's get your perspective.
Perspective, healthcare delivery is getting ground because apart from the state I told you, they are also in Brazil. Like other states that are coming with the initiatives like Imo, Oyo, Ogun, Rivers. This state has accepted to come out to ensure that there is a community-oriented nursing and midwifery program that goes into the grassroots and ensure that the same modalities that were adopted by Women for Health is also being trying to exhibit it in their own state so that they can be able to identify professionals that are interested from that community, train them, and allow them to go out to the same community. And that's also what is part of what is happening at the community medicine or community nursing and community midwifery at the community level in order to bridge the gap, in order to address the challenges of the shortage of this manpower at the state. And I believe other states are looking at the importance and the benefit of these programs from the state that has started. As I want to tell you that it is a record now, almost 10 states have started, and they have started producing these professionals. And we have so far produced over 3,600 community midwives, and we have registered them as licensed community midwives that have started working and making a lot of positive impact at the community level. And a lot of strategies are put in place of retain them by their, because we don't want to train them and just throw them at the level market. No, it is designed to identify them, bonded them. At the end of the training, they will be employed and go back to the same community. And these are the strategies also, like what Dr. Ebere has said. They have not tested the light or the issue of what is happening in the other developed countries. So they have the issue of brain drain is not in their mind. The issue of living in the country is not in their mind. Rather, they are to be trained and go back to that community. And this is the focus. And I want to appreciate that some of the state has started appreciating and see the impact of it, and they are coming on board. Like I told you, so the training is ongoing, and so many states are coming on board to accept this the strategy in order to have available and accessible and right number of quality and quantity of nurses and midwives at the grassroots.
To Anyachuku, do Dr. Anyachuku do you before I come to the National Program Officer? Dr. Anyachuku, in line with what we are discussing tonight, in few words, what will you say about passion in healthcare delivery, briefly?
Passion is very important in healthcare delivery, because that's being a health worker is not easy. You deal with a number of difficult issues every day. You interact with people's lives. Sometimes the decisions you make might be life and death for people. So in delivering that healthcare, you need to have. It's important to have some passion for what you are doing. That's what drives you to continue to do that. Every person who delivers healthcare, it's when you are doing the training, when you take the decision to go into healthcare, and when you're actually doing the training, and then when you do it, you realize that what you're doing is not just a job, it's a vocation. It's something that makes such a huge impact in the lives of so many people. And that's one of the things that we've also tried to, in the training that we've been providing through Women for Health, is to bring some of that passion back and to help our nurses and midwives to recapture that relationship that they have with their patients, so that patients are treated in a humane and treated in much better ways than many people are used to. And we've seen so far that when that happens, you find more people willing to go to the health center. And I was speaking with a woman in I think in Kano just last week, who basically it was the passion that she saw from the midwife that had just been trained and had come back to her community, and the way the midwife was treating her, which was very different from the way that she was expecting. That really encouraged her to come to the facility to give birth, and she was also encouraging other women in the community to come to the facility. So that's something I think we really need to bring back into the profession, and I think we've been able to see that this does make a big difference.
Ebere Anyachuku, Health Advisor, UK Foreign Commonwealth and Development Office. It was nice having you on Tuesday Live tonight.
It was nice being here.
Also tonight we had Farouk Omar Abubakar, Secretary General, Registrar of the Nursing and Midwifery Council of Nigeria. Thanks so much for making time to be on the program.
Thank you. It's nice to be with you.
Yeah, Dr. Fatima, just in a few words, where will you project Nigeria be if this program, as it is exiting in the 6 focal states, other states are taking it up? Community medicine in Nigeria, maybe in the next few years?
If we can get all the states, I assure you we will have our women, using this same approach, we will have our women delivering in the hospital, not only delivering in the hospital, but also they are treated with respect and with dignity. And the problem of women running away from hospital because of the disrespectful treatment they get from the health workers will be the story of the past.
What do you tell to governors who are yet to key into this?
We're inviting them to key into that, not only because they need to do that, but importantly because that is what I'm now talking as a woman. As a woman, that is what we're demanding. When I'm giving birth as a woman, I want to give birth with somebody that respects me and will treat me well. And I think that is the least as a woman I can ask from my governor. Please let me have a qualified health worker with me when I'm giving birth. And I don't think we're asking too much. And that's what we're asking from all the 36. I'm asking all the 36 governors plus the Minister of Abuja. Let's have women, when a woman is giving birth, let's have skilled birth attendant woman attending to her.
Thank you so much, Dr. Fatima Adamu, National Program Officer, Women for Health in Nigeria, W4H.
Yes,
that's it on the program. We looked at Women for Health bridging the gap of female health workers in the country. And while the program lasted, we got your tweets, we got your phone calls. We thank you so much for your tweets, and we thank you so much for your phone calls. That's it on the program. On behalf of all of us, thanks for watching. Bye-bye.